everyone. This is Marcy Nielsen. I'm the CEO and President at the Patient-Centered Primary Care Collaborative, and I am so pleased to welcome you to our May National Briefing webinar. The topic for today's webinar is the role of nurse practitioners in providing patient-centered care, and so pleased to be able to introduce our guests here in a moment. I'm going to stop for just a second and offer a couple of housekeeping items before we begin. First, many of you have been closely tracking Medicare payment reform, and if you haven't, I suspect you soon will be. We at the PCPCC have certainly been tracking it and want to point you to a number of resources that we've developed, first and foremost that can be assessed on our website, and so you'll see a number of those resources listed for you. In addition to tracking payment reform via MACRA, we are also closely tracking the Comprehensive Primary Care Plus program. There's a deadline coming up to get Medicaid programs and health plans signed up by June 8th. So I want to encourage you to do that, and again, head back to our website for additional information. Secondly, I want to make sure that you've got your calendars marked for our 2016 annual fall conference. It is our 10-year anniversary, and so we are going to be mixing it up a bit this year with a memorable celebration. Love to have you all join us. We've got information on our website as well at PCPCCevents.com. So please take a look and plan to join us in Washington, D.C. at November 9th through the 11th. And then finally, many of you are joining us for our webinars and have an opportunity to hear from national speakers, community level folks on a range of topics that impact primary care. Many of you then go on to join the PCPCC as an executive member, as a not-for-profit organization. This is the number one way in which we fund our organization, and so always interested in having more of you participate, and information about executive membership is also available, or you can contact Amanda Holt on our team, but the website includes lots of information about executive membership. And then the final note before I introduce Cindy and Sean is just how to use the webinar software that you have all signed into. I think many of you have been on Citrix before. You see that there is a capacity during the presentation. You'll see a drop-down question box on the right side of your screen. You can ask questions as we go, and then during the last 15 minutes of our webinar, we're going to open it up for Q&A from all of you. And as many of you know, we do share the slides and the recorded presentation about 24 hours after our webinar. We will at some point be moving all of these webinars into a way in which to organize a curriculum. So stay tuned. You'll see some changes in the future, chunking information together that hopefully will be able to be a good resource for folks who like to listen to webinars and podcasts. So without further ado, it is my great honor to introduce both Dr. Cindy Cook and Sean Lyon, who are nurse practitioners with lots of experience in offering patient-centered care. Cindy is the current president of the American Association of Nurse Practitioners. She is a board-certified nurse, family nurse practitioner herself from Huntsville, Alabama, and she completed her doctorate of nursing practice at UAB with a focus on health literacy. She's been very, very busy in local, state, and national organizations related to nurse practitioner leadership, and we are so pleased that she is here with us today. Sean Lyon serves as an advanced practice registered nurse and family nurse practitioner with a postgraduate completion with the Institute of Functional Medicine certification at Richer Wellness MD in New London, New Hampshire. and he's got lots of experience working, taking care of patients, but also contributing to various organizations that want to promote patient-centered care to include the PCPCC, as well as working on committees that seek to improve the quality of care delivery, like NCQA and URAC. So without further ado, I am going to turn this over to Cindy and to Sean, and again, we'll be spending the last 15 minutes doing a bit of Q&A. So type in those questions, and Cindy, Sean, thank you so very much for being here. I should mention I am a big fan of the CEO of the AANP, Dave Hebert, who serves on our board, and so very much appreciate the way in which nurse practitioners continue to help patients and families and communities in promoting health and in improving what we're trying to do at the PCPCC. So Cindy, I'm going to turn it over to you first.
Great, thank you, Marcy. First of all, I would like to thank the PCPCC for the invitation and the opportunity to talk about nurse practitioners and the care that NPs provide to our patients. And so on that, we'll just jump into the presentation and just a little bit about who nurse practitioners are and what we do. We start with a bachelor's in nursing and are licensed in whatever state we practice in. We've pursued graduate education and are become board certified nationally, and then we are state licensed and registered in whatever state or locale that we are living or working in. At some point, it is recommended that a doctoral degree, either a DNP or a PhD, become the terminal degree to prepare nurse practitioners for entry into practice. And so more to come on that. Nurse practitioners are definitely licensed by each state that they work in, and they are nationally certified. There are 5 certifying bodies depending on the type of nurse practitioner that you are educated to be, and we'll talk a little bit about that later. The 2 organizations that certify the majority of nurse practitioners are the American Academy of Nurse Practitioners Certification Program and the American Nurse Credentialing Corporation, or ANCC. They credential or certify most of the majority of NPs. Nurse practitioners recertify every 5 years, and requirements for CE vary by the certifying bodies, but also by the state licensing bodies. Typically, it's about 100 to 150 CE hours every 5 years for recertification. There are other ways that you can do that other than CE for certification, which can be publishing or precepting, and those can be accepted up to a certain point in lieu of how many CE hours that are required. And part of the CE requirement is a specific number of pharmacology CE credits for both licensure and certification, as we feel it's very important to keep up with the pharmacology and prescriptive practice. So as you can see on this chart, NP growth has been very rapid. This data is from the 1999 years all the way through 2015. The way that AANP gets this information is through the boards of nursing imports through the years, and so we usually update these numbers in January and July of each year, and so it is very satisfying to me to see the continued trajectory of the growth of the NP workforce that provides care to patients each and every day. And from this you can see that there's also a growth in new NP graduates each year. There are nearly 400 universities who offer nurse practitioner programs nationwide, and approximately 17,000 new nurse practitioners graduated in the 2013-14 school year. We will have the 2014-15 data out in July of this year, but it's always interesting to see how many new graduates are entering the workforce each and every year. So nurse practitioners have a number of focus areas, which you can see on this slide. It's really interesting to see that most NPs are in primary care. Nurse practitioners are educated, licensed, and certified in a population focus based on the National Council of State Boards of Nursing consensus model. So you can see the list of different kinds of NPs on this list, on this slide. Gerontology is one that you would think would be big, but is now, the numbers for just gerontology are actually going down because that has now been combined into an adult gerontology combined certification and education. So we are meeting the needs of adults transitioning into the gerontologic time period of their lives. And I'm very thankful that there are a lot of people who want to do that as I get older. So it's always interesting to see where our next thing is. And I cannot get the slide to advance. Okay. So NP scope of practice includes diagnosis and management of acute, episodic, and chronic conditions. Nurse practitioners have an emphasis in health promotion and disease prevention. As a nurse, I took care of many patients in the hospital, and over the course of my career, I really wanted to keep people out of the hospital. And going forward, as a nurse practitioner, as a family nurse practitioner, that is my goal, is to keep people out of the hospital and healthy. So NPs can order, conduct, supervise, interpret diagnostic studies. We prescribe medications as well as non-pharmacologic therapies each and every day. Nurse practitioners have prescriptive authority in all 50 states and the District of Columbia. And on this slide, you can see just a few examples of the multiple diagnoses that are treated by nurse practitioners. Nurse practitioners treat patients wherever they are and whatever their complaints are, and work as part of the patient-centered medical team to treat these patients at the highest level of care that we are educated and clinically trained to do. Nurse practitioners are authorized, again, to prescribe in all 50 states and the District of Columbia. This includes controlled substances, although that level varies from state to state as to what controlled substances that can be prescribed and for how long. That's actually a state-determined thing. Almost 100% of nurse practitioners prescribe. It says more than 700 million prescriptions annually. This says that nurse practitioners in full-time practice on a recent survey wrote an average of 21 prescriptions a day. I would say that that varies from day to day. There are days that I felt like I had written 21 by 9 o'clock in the morning. There are days that I didn't write nearly that many. And I think that always is really important when you are meeting the needs of your patients as to what they need. I would note that 100% of nurse practitioners that work in rural communities prescribe medication. So I think that's important to look at as well. And these are examples, just a few examples of medications that nurse practitioners prescribe, because we want to make sure that our patients are being well taken care of with appropriate evaluation and diagnostic tools, but also with appropriate medication. And these need to be reviewed with each patient every time they are in a clinic visit to make sure that we have a really accurate list of what patients are taking and what they really need to be taking and what they may not need to be taking. So this also includes not only medications but vaccines each and every day to keep our population healthy. So practice sites, nurse practitioners are found anywhere people are. So we can be found in urban areas, suburban, rural communities, and we work in a multitude of different sites, such as outpatient clinics, urgent care, convenient care, inpatient, as well as the emergency room, but also in community clinics. And we really work in all types of settings for a very diverse population. Many nurse practitioners really work hard to care for underserved populations, both in rural and urban areas. So the NP workforce, you can see that the specialties by year, they don't add up to 100% because there are 3 additional specialties since 2000. Only 3 existed in 2003, so it's not going to make sense if you just look at it trying to add everything up to 100. But it's really important to see that adult and family and adult gero are really the primary places that NP growth is. The top 2 NP subspecialties that we find in our data is cardiovascular and emergency room. That we complete these studies every 2 to 3 years to see where our NP workforce is, and it's always exciting to see that NPs are meeting the needs of patients where they are each and every day. So nurse practitioners are educated and clinically trained to partner with patients on their healthcare journey. It's really important to see a patient as a whole individual, as part of a family and a community. And we really strive to partner in health by engaging patients and their families in shared decision-making to accomplish the desired goals of health. NPs provide high-quality and affordable patient-centered care, and I always want to emphasize the patient-centered care. It's really important to know that the patient is the center and the focus of what nurse practitioner care is all about. And there are 3 studies here that are listed that showed among Medicare patients with diabetes, receipt of primary care from a nurse practitioner was associated with a decreased risk of hospitalization for potentially preventable conditions such as uncontrolled diabetes and other kinds of hospitalizations, and that's the CUO study. And the PERLOS study shows that primary care nurse practitioner assigned Medicare beneficiaries cost 15% less than Medicare beneficiaries assigned to primary care physicians. And that was in a total cost when adjusted for work resource value unit, or RVUs, and other key demographics and comorbidities. The Richards and Polsky study showed that clinics with more nurse practitioners and PAs were associated with better access for Medicaid patients and lower prices for office visits. Now, of note, those relationships were found in states granting full practice authority, and we can find out more on our website about that if you'd like to. So nurse practitioners, as we know that the primary care system is definitely evolving, and nurse practitioners are meeting patient needs by increasing access, increasing quality, and improving the timeliness of care. So really what we want to do is provide a high quality at a lower cost. Jobs for nurse practitioners are growing in number, which provides an economic benefit to the state. And nurse practitioners currently make up about 1/3 of the primary care workforce. What I also always want to focus on, again, is that the patient is the center of the healthcare team. The patient and their healthcare providers make up this team. The health team to us is dynamic. So the needs of the patient really direct who can best lead the team at any given time. And that can change depending on the needs of the patient. And on that team, every member of the healthcare team should practice to the fullest extent of their educational preparation and clinical training to meet that patient's needs. That really encourages mutual trust among all participants on that team and helps the patient identify and support their goals as to what they want the outcomes to be, as well as what the team can provide to that patient. Just a couple of things about legislative things that can help with nurse practitioner care is our goal as from AANP is to eliminate all barriers to practice for nurse practitioners. NPs have been at the forefront of providing primary health care to patients for over half a century and are definitely leading healthcare providers of the future. The academic and clinical education that equips NPs to assess, order, and interpret tests, make diagnoses, initiate and manage treatment plans, and prescribe medication is part of the expert preparation needed to address the healthcare challenges that our nation is facing today. More than 40% of states at this point in time have adopted full practice authority licensure laws, which authorize NPs to provide the full scope of advanced nursing services care under the exclusive regulatory oversight of the Board of Nursing in that particular state. Many of these states have had this particular kind of regulatory situation for over 20 years and really see positive trends around patient care outcomes and increasing the provider workforce. In the last 5 years, 7 states have adopted this licensure model for NPs, and this year several states are also considering modernization of their Nurse Practice Act as well. So licensure issues are not really a nursing issue, it's a patient care issue. It's a community issue and a global issue. Research consistently demonstrates that access to timely health care improves outcomes and really improves the health of our communities nationwide. And there are additional federal issues. I'm not going to read all of these to you, but I will kind of touch base on addiction treatment because, as we all know, we are in a healthcare crisis when it comes to addiction, and nurse practitioners are on the front lines of treatment of patients each and every day, and we feel that they should be allowed to help with this epidemic that we have right now each and every day. So I appreciate everything that the PCC is doing to work with multiple different organizations in improving patient-centered primary care. And I will hand this over to Sean, and he can tell us a little bit about his personal experience in this.
Thank you, Cindy. And Sean, I'm going to just for a minute and thank you for all of your leadership, Cindy, and certainly Sean in a moment. I want to make certain that folks who are listening to the webinar recognize that the focus of the PCPCC is on advancing primary care that, as you pointed out, Cindy, really serves our nation and our communities. And the goal is patient-centered care that includes families as members of that care team. We do not, as an organization, take on issues relative to the scope. We don't take on issues at the state level around scope of practice, nor at the federal level. But we do strongly believe in the team-based care model that includes patients and families. And so we just want to make sure that as you're sharing some of the important priorities of your organization, we don't have anyone misunderstand that there's that your presentation today is pushing for scope at a PCPCC policy level. We just feel like it's important information for all of our audience to be aware of the various ways in which nurse practitioners support health and patients. Oh, sorry,
Thanks,
Sean.
Marcy.
Thank you,
I
Cindy.
agree.
Take it away, Sean. Sorry about that.
Well, thanks, Cindy, and thanks, Marcy, Amy, and Amanda. Much honored to be able to give a presentation for you all. Last time I was doing something of this sort regarding the medical home, I'm glad to say I'm now on the webinar rather than in Washington, where I almost spilled coffee on Elliot Fisher before he did his keynote presentation, and then the entire Reagan Convention Center had to empty because of the fire alarm being pulled. So this should be a much easier presentation for all of us today. We can relax and enjoy our coffee or our lunch. So my goal at this point is to give you a little bit of an overview of how lifelong care went through medical home designation, the quality and cost indicators that we had with some success, and then the evolution of that so that we have gone from 1 clinic to now 9 nurse practitioner-led clinics working in collaboration as a part of the Anthem project and the great successes we're having here. So I don't need to go into much detail here for most of you relative to the definition of a medical home. However, I would like to spend a moment being able to recognize that lifelong care was focusing in great detail on the team-based care all the way back in 2008 and continued, and that's a big piece of what the 9 clinics are doing at this time. So lifelong care, in order to move forward, when we joined into the project in New Hampshire, had to do a fair amount of soul searching, which is incredibly important, as we all do when we're trying to figure out whether we can be successful in anything, which came back to the beginning, which is really what's the foundation of who we are and why are we doing this, which was our mission, vision, and values. And it was developed as a clinic with the idea of creating that safe space where we were modeling that safety for not just the providers, but also the patients, and to extend safety as the opportunity for the open communication, which led to the foundation of putting together a nursing model of relationship. And the only way you can truly have relationship is with that safety in mind. So the team at that time were the 4 APRNs, the registered nurse, as well as the MA office manager and receptionist. We had outside business assistants in a variety of ways, being a private practice. So we look to patient-centered care really from a very basic and pragmatic approach, rather than trying to come up with an academic definition. And we put it out there as to what impacted each of our patients on a very emotional level. And when we were sending messages out to each of the patients for significant events in their lives, or we had their pictures on the walls or their comments through our website, et cetera, that was part of that relationship that we were building on, so that they knew they were a part of what was happening. As you can see the handprint there, those are the kids, as well as some of the adults and even the local pediatrician who had their hands on the wall in the kids' room. So we were part of the Citizens Health Initiative at the beginning, and we were the 1 NP clinic that was invited to join. And we were able to get the assistance for evaluation of our strengths and weaknesses to move forward in the entire recognition process for NCQA. And that was incredibly powerful process for us to do that. And hats off to the groups that were supportive of that process. So as many of us will remember from our gray hairs, the prior definitions of what were required for the medical home, which is want to harken us back to that yesteryear as we look at some of this, so we have a reference point, because we obviously have evolved in healthcare to see the growth opportunities, and continuing to see NCQA as well as URAC and other organizations, see relationship building and care coordination in a stronger way from the 2007 standards. So Center for Medical Home Improvement did that full evaluation for us, and those assessment evaluations are still available through their website, so please recognize you can access those as well. So our payer distribution was a little bit unusual for a clinic to have such a high commercial, so certainly filter this information from that perspective. When we were going through our evaluation, we were measuring based on prior, the current year of 08, and then after submission in 2010. And as you can see, there were some areas where we were doing improvements and then maintaining those improvements. And interestingly, some of the pieces I left out from this set of slides were the areas where we had electronic health record discrepancies, which did not allow for us to do any of this. And since this time, the new EHR has allowed us to do some of the additional requirements of care coordination and monitoring, which is always the part of that. So the next two slides are interesting to me, and that it gets down to some of the details of where were we relative to the actual data that says, wow, you're doing pretty good. So this is a slide that tells us about how we were referring to the emergency room and how often we were doing that and what sort of successes. So our total of 158 with our rate per 1,000 at 292 was, if you look at the other clinics in the out of the 9 that were in there, that is well below the average that we ended up having for the entire state. And then from the other side, when we were, I'm sorry, I'm not sliding the way I want to, there we go. We were continuing to do this over time. So when we began to see our successes relative to the referral side, we were looking at the individual cost, comparing ourselves. So you see the blue, the red, and the green. Lifelong care was in the blue, and we were staying below cost in each of those segments as outlined on the bar graph. And this is the cost by practice being a part of the pilot project. And then when we looked into how we were doing this as we went forward, as we have moved into the next stage outside of the pilot, and then being a part of the Anthem program, which is now 9 clinics that are working together, we now have essentially the second stage where instead of the 2,500 patients to 3,000 that were being evaluated, we now have about 50,000 that are being looked at. So as you can see, the blue for the New Hampshire APRN panel, how that is routinely above what we're seeing on the market expectations and the successes that we're having here with the quality indicators. And I'm sorry for the quality of this slide, trying to increase what we get from very small pictures. But this is a small output that you have here from one of the other clinics for Wendy Wright in Manchester, Amherst area of New Hampshire, showing some of their quality indicators for what they're doing relative to diabetes. And that was just one segment of the 30 indicators where they're having some success. So there are numerous things that we really want to look at to improve our ability to continue work, to have the changes with improvements regarding cost, which we have clearly demonstrated that we've contained and saved, as well as the improvements regarding quality. And this is going to require continued improvements relative to a variety of relationships between organizations, continued focus on primary care in order to maintain these successes. Our continued work within a scope of practice which we have here in New Hampshire has outlined great successes, and we will be maintaining the same methods as we've noted the successes to date. As team leaders in the NP-led clinics, these cost and quality indicators that we've had success with demonstrate the NPs can lead the teams. But I think going back to what Cindy recognizes, that the patient is at the center of that team and the NP is recognized as a part of that. We hold responsibility to it, but we absolutely maintain that the patient is the primary focus. So a few resources here, and I will end with the final slide if all works out well, as a great thank you to my mentor, Kitty Kidder, and unfortunately she's not able to be a part of this as she's working on her bucket list in our great state of Wyoming, enjoying a little bit of retirement time. So to that I sign off, and thank you very much.
Thanks so much, Cindy and Sean. This was a great presentation. I want to just encourage everyone to go ahead and submit their questions into the chat, and we can ask those questions. You can indicate if you'd like to have the question asked of either Cindy or Sean, or we can just pitch it to both of them, and they can field them as they like. You know, Sean, one of the things that I was thinking about as you were talking about your presentation was around organizing the whole team. As Marcy was indicating, you know, we really focus a lot on how do we better provide all the services that patients need in their communities, and really having everyone have the right skill set on that team to do all the care that's needed for you know, oftentimes a pretty diverse patient population. What are some of the strategies that you employed with your care team to make sure that everyone was talking to each other? Did you employ kind of like team huddles, or how did you make that care most coordinated and communication effective across all the team members?
Oh, great question, very practical. So a couple of pieces. One where we routinely did the huddles. The other piece is we did our best to educate and advertise to those we are serving where our interest and special advanced pieces of education were, so that the patient was able to choose at times which of the providers they may want to see about a particular issue. So one of the providers was incredibly experienced in cardiovascular issues, and as well as another one with oncology. And so folks were sometimes deciding to make their appointments in that regards. And we actually did not have panel per se for the patients, because we wanted them to be able to choose at their discretion which provider when they would see that provider, so that it created the responsibility for the patient as the team rather than a single provider. And it was an interesting model to work from that way.
Yeah, absolutely. That sounds like it. That kind of goes along with one of the questions that was just submitted. Who are some of the other members of your team? Like, how did you have team members that particularly address behavioral health issues? Did you have social workers, community health workers, collaborations with other providers in the community that you incorporated as part of your team?
So we had a nurse that worked with us at a very strong nutritional interest, and had gone through some advanced training with me in that. One of the NPs is also duly certified as a psychiatric NP. And then two of the other NPs had, as I had mentioned, one had a strong background in cardiovascular inpatient patient work, and the other one with a background in oncology.
And what about, did you have any partnerships with other agencies or organizations in the community that would help build out your team?
So we were all on medical staff of the local hospital, so we had that automatic relationship built in from that side of it. Most of us had actually worked through the hospital system, so we had a day-to-day working experience in relationship with many of the providers there, the surgeons, et cetera. We had a diabetic educator that was working almost directly above us, and she would actually come downstairs occasionally to use one of our office areas because the building does not have an elevator. And so for some of the morbidly obese or other challenges for folks who weren't able to walk the stairs up to her office, she would come down on average once a week to use our space. So we had that sort of a relationship with a variety of folks. And only one door down, we had an internal medicine specialist that we did coverage for, or once in a while he did coverage for us, and we worked in collaboration with him. And we had a pharmacist another door down from him that we were routinely working with. And it's that sort of a neighborhood connection that in small town works incredibly well.
Yeah, I think that's a really great model, because a lot of times even just co-locating in the same space can really improve access for patients, especially as we talk often about the integration of behavioral health. Having somebody just there on site who can provide some of those services reduces some of the stigma that the patients might feel in going to a place that has labeled, on the billboard, the mental health services right there. So I think that's fantastic. What are some of your strategies that you employed in your practice around kind of ongoing quality improvement? Did you use patient surveys? Do you have patient family advisory councils? What are some of the ways that you identified ways that could be continually, because in terms of how we're talking about all around transforming care, especially in the ambulatory care settings, this idea of continuous quality improvement always rises to the top, and we know there's never an end to that journey, kind of even around patient-centered medical home. You never really quite achieve that destination because you're always working to do better. What are some of the philosophies that you embraced, or specific strategies on that front?
So I have, I guess I go back to the very basic piece of that. Kitty's model was one in which we always eat lunch together, and magic happens when you have a relationship, and there were no stupid questions. So when the receptionist or the janitor or whoever has an idea, those ideas had the same value as somebody coming to us from Dartmouth Institute. Yeah, everything was routinely put in the box, and we were coming up with the basic practical solutions, but always trying to build from the positive. So we were doing random surveys with patients at least once a month. And we had started off doing a simple sort of a 5-question Likert scale, which, as most of us know, when you just do a simple Likert scale, you get back sort of the answers that you want. And we abandoned that after a while, recognizing we wanted to have open-ended questions, therefore we would get fresh new ideas. And from that, we were able to make some simple changes for folks, and that's where we were trying to evolve, like the group visits and other options where folks wanted to be able to tell us what they wanted so we could move with their requests rather than us doing what we thought they wanted.
Perfect. Yeah, I think it's really important that everyone feels that they have a role in improving the system of care. Absolutely.
And so the other one, to give an example of this as well, what Wendy Wright has been doing with her clinic, and the feedback they had were regarding telehealth visits. And so at her clinic now, they have telehealth 7 days a week from 8 to 8, and they've had well over 250 visits since February 1st, just in that simple thing, and that evolved partially through patient feedback. And that's a quality improvement project that is expanded well beyond simply improving some quality. It's expanding access and services, and obviously reducing costs for the patients as well.
Fantastic. I just wanted to give one quick shout out to everyone who's participating. A lot of people have asked for links to the resources and the articles that were referenced, and again, we'll have a copy of the slides available up on our website by the end of the day tomorrow, so everyone will have those, and provide a specific link to those as well. Marcy, I think you had a question that you wanted to pitch to Cindy at this point.
I do. I actually have a couple of questions, and these I want to thank Sean for contextualizing some of what Cindy was talking about at a 60,000-foot view. I am a policy person, so I can't help but come back to some policy issues and how nurse practitioners' role continues to evolve as we elevate primary care in the U.S. health system. I think most folks recognize that most other industrialized countries spend 2/3 to 3/4 of their health care more closely related to primary care, or what we call upstream spending, so that they spend less money on emergency rooms and hospitalization. And in the United States, that number is flipped, and it's related to the number of healthcare providers we have in primary care versus specialty care. So the growing role that nurse practitioners play is an important one, and so I guess I have a couple of different questions that relate to that. One is we know that retail clinics, for example, are continuing to utilize the expertise of nurse practitioners, particularly in hard to reach settings in terms of rural areas, in some underserved urban areas. So if you might talk about the training and how, Amy asked about teams, how we can provide the kind of important aspect of primary care that is continuous care, longitudinal relationships at the same time, and that's the concept of the patient-centered medical home. And yet we run up against access problems in rural settings and in underserved settings, and so the importance of retail clinic growth and utilizing the skill of nurse practitioners. That's sort of question number one. And then question number two relates to payment reform, because so often what we're finding is that the real barrier to access to care, whether it's nurse practitioners or physicians or PAs, at some point really does get back to paying and valuing primary care. And how nurse practitioners are getting involved in payment reform. Do you see a differential between what primary care nurse practitioners are paid relative to specialty nurse practitioners, and the role, many folks on the phone probably recognize this, but MACRA isn't just about physicians. MACRA is payment reform for nurse practitioners as well. So sorry for the very long-winded question. Cindy?
Yes, that's a lot. Let me go to your first question first, with the retail clinics and how nurse practitioners are being utilized there. I see the retail clinics and convenient care and urgent care as a response to patient demand for care, when they need it, how they can get that. Because I have a lot of colleagues who work in retail clinics, in convenient care clinics, who say that they, encourage their patients to go to their primary care provider and they can't get in for a week. Well, if you're sick today and need to go to work, or have a sick child and you need to go to work, that's a problem. And so patients need to be taken care of in a timely manner and have the access to care that they need. Most of those convenient care clinics do a really good job of getting the information back to that patient's primary care provider, so that they can have a good continuity of care. And so that's really important. But I think that model of care was born out of patient demand and patient request of, I need to be seen in a timely manner because I'm sick today, not a week from today. Or I've been sick for a week and I still can't get in to my provider for another 4 days, and I'm missing work, and my child's out of school, and so I think that the patient demand has really brought that to bear, and that's where I think that nurse practitioners can help meet that need of meeting patients where they are. And just like Sean said with Wendy Wright with telehealth, I think that is huge in that sometimes really all you need is an electronic or a phone visit to say, these are my symptoms, this is what's going on, and it doesn't necessarily require you to come to the office and do that. Many needs can be met that way to do that. Now, sometimes you do have to go in and see your provider. My provider calls me and says, we haven't seen you in a while, you need to come. Okay. So, and I think that there are times that it is definitely appropriate. And again, nurse practitioners, I really feel like, make a focus on the patient as part of a family, as part of a community. And as far as payment reform, there are barriers to access to care depending on what state you live in. That's a real challenge depending on where you are. Payments to nurse practitioners oftentimes are at 80, reduced amount, and so I would purport that a nurse practitioner-led clinic utilities are still the same as any other clinic. Their rent is the same. They need to pay their employees the same, and so getting a reduced amount of money for the same care that others provide is a challenge. It's a real problem to me to see that. You asked something else, and what am I missing?
No, you're hitting on the really important points, and I do think, given that I'm from a small town, rural Nebraska, the piece about patient demand is critically important, and your point about the use of technology, and Sean's as well. We've got to have telemedicine opportunities, and we need to have medical records that allow us to share information back with the primary care provider. But there is no doubt that the demand for retail clinic growth is directly related to what consumers expect and need from their providers. On the payment reform front, you'd mentioned, everybody's got to pay the same amount of money to keep their doors open, whether you're running a nurse practitioner clinic or a physician clinic. And one question that I sort of touched on was the fact that MACRA isn't just about physician payment, but it's also about nurse practitioner payment. And if you maybe had any thoughts, there are lots and lots and lots of details to sift through in the 963-page MACRA proposed regs. But if you had a global statement about what they're looking like, I didn't know if you wanted to share that.
Well, I'm not going to say that I've gone through all 900 pages because I have not, and I think that the details are still coming out, and I think that we just need to continue to be open-minded and innovative in payment models and in meeting the patient's needs where they are. But I think also that if we partner with our communities and help the communities be healthier with, implementing fresh fruits and vegetables to urban areas that don't have that access, where there are what we call food deserts, that they really don't have access to that, where we can energize our children and our families to move more, to be active, to be outside, to do things that will actually be health promotion, and then that we avoid so many of the chronic health diseases that we are faced with each and every day. And that's one thing that I really feel like in the United States we face that all the time, because we really haven't focused on health care or health promotion in our current healthcare system. We are really more of an episodic sick care than healthy promotion. And so that's where I feel like nurse practitioners are in a key position to really work with families and communities and doing that, encouraging that, whether it's working with schools or the mayor or the city council to really implement some of these things in promoting health. And I think that will decrease our healthcare costs tremendously.
Marcy,
and I think, go for it, Sean.
Well, I was just going to point out on the other side of the reimbursement issue is that the NPs in the state of New Hampshire helped Anthem with $3.6 million paid out to the providers in the shared savings program that we're a part of. So that's a fair amount of data there showing that there's quality that's been proven, and the reimbursement is being improved upon for the folks in the primary care world when they do what needs to be done. I think we can't lose sight of there are many different reimbursement models out there, and one of them is beginning to show some support to put it back into the infrastructure for those primary care clinics willing to put that extra upfront energy to make it work. And I know it's a lot of work, but it is paying fruit for some of us.
Yeah, that's important, and folks need to be able to know that all this hard work will ultimately pay off, not just in terms of the clinic itself, in terms of getting to take advantage of the shared savings, but even to the larger point that Cindy's making, which is near and dear to my heart, which is big picture public health, population health. We can and will save dollars when we are focused on health and not just health care. And that is an increasing goal at the PCPCC. I happen to believe that the medical home, advanced primary care, whatever you want to call it, really is that place where clinical care meets public health, and it's where there is the most promise. Amy, I can see we are at the top of the hour, and so I should probably sum this up by saying, again, thank you, Sean, thank you, Cindy, for joining us. We very much look forward to more collaboration with our colleagues in the nurse practitioner space, in the nursing space. Amy's point earlier, social workers, community health. Health is owned by all of us, and when we think about health care, we're missing the social supports necessary to make all patients and families healthier. So stay tuned for more of these kinds of presentations, and thank you everybody for joining us.
Yes, thank you everyone, and have a happy and safe Memorial Day weekend. Bye-bye.
Thank you very much.